morning, JP. How are you?
Very good, Shanmugam. How are you doing?
Wonderful, wonderful. Great. So I know you've done a lot of projects with many different analyses. So what are things that you identify as problems with the patient level data recently?
PLD, I think that basically the holes in the data, the capture is not complete, the biases in the data.
Yeah.
And then the anomalies, for example, that you have, the data vendor gets the data from data suppliers and sometimes they lose them or get additional ones. So that creates kind of little havoc in the data.
Uh-huh.
But I think the most critical one is duplicate patients in the PLD data. Yeah.
So you mean like the same patient will have two different IDs in the patient level data?
That's correct. That's correct. And based on our measurements, in some cases, it's up to 10%.
Oh,
So
wow.
when there are really 100 patients, what's reported like 110.
Oh my God, I know that will definitely create a wrench in the analysis. So how bad is this that we need to treat it?
Oh, you have to take care of it. You cannot kind of sweep under the rug.
Mm-hmm.
Because one may think, okay, the data capture of the PLD is we don't capture everything, so it's kind of under capture.
Right.
And then we've duplicated to kind of make up for what we're not getting.
Yeah.
But that's flawed.
Okay.
That's flawed because for the same patient, what would happen is you'll get more patients than what that physician really has. So any tactical decision that you make, you have to use the real data.
Okay.
So you gotta just assume that it's going to make up for it.
Right,
That's wrong thinking.
I see. Okay. So, then because we don't know, the patients are all encrypted, right?
Yes.
We don't have access to the PII,
Yes,
the
yeah.
first name, date of birth, and things like that. So how can you tell if this patient ID is the same as this one?
That's a very good comment.
Mhm.
So normally you should have the PII.
Right.
But then here's the kind of our thinking is that if you look at the overlapping claims, the
Right.
claims overlap to such an extent
Uh-huh.
that it cannot be fluke.
Oh.
So they have exactly the same schedule, take the same things, same procedure, same surgeon, same everything.
Right.
And they are different patient IDs. So we know those two patient IDs can only correspond to the same patient. This is how we know.
Wonderful. Nice. That's a
Yeah,
great
yeah,
way to
yeah.
kind of triangulate.
Yeah.
So what is the source of this problem, JP?
So the source is that when you look at the data vendor,
Mhm.
the data vendor gets the claim from, say the patient goes to the pharmacy. So you get a copy of the claim.
Right.
And the claim makes its way to the payer to get reimbursed, right?
Right.
And so it goes through the clearinghouse that's going to adjudicate, make sure everything is kosher
Right.
before it's being paid.
Yeah.
So now there's a copy of that claim that comes to the data vendor.
Mhm.
And then when the claim arrives to the payer to be paid,
Mhm.
if there's coordination of benefit, maybe it's got several payers involved.
Mhm.
So you can get 2, 1, 2, 3.
Right.
Now all of a sudden you can see there are like 5 different copies of the same claim that the data vendor sits on.
Okay.
And the name of the game is to remove those duplicates because there's only one transaction.
Exactly.
So you have to remove them.
Oh.
That's
yeah.
why. So the leftover, when they don't do a very good job,
Right.
this is where you have those leftover duplicates.
Correct. Okay, I think I'm on board with you. So what can we do about this? Because we can't. Do we work with the vendor, or how do we kind of?
Yeah,
mitigate
so
this
basically
problem?
what we need to do is, what we offer is we have an algorithm
Right.
called the magnet algorithm that basically identifies the duplicates.
Okay.
And then the next step is to, as you can guess, to remove those duplicates.
Exactly. Right. So we'll once we identify them with the magnet algorithm, and if we remove them, I think we should be good, right?
Yeah, except that it's a little more subtle for the reason that if you have one patient that has say 20 claims, one patient ID, and then a second patient ID has 30 claims, you may want to kick out the one with 20 claims that were done.
Oh.
But it could be that patient one with less claims has claims that do not appear in the patient due. So what you want to do is to enrich before you throw it away. You want to take those claims that don't appear and throw it away. We call that the Frankenstein patient because you kind of take one leg here, you take an arm over there,
Right.
and you put them together. That's we call them the Frankenstein.
That's kind of a
Yeah,
funny way
yeah.
to describe that.
Yeah.
Awesome. Yeah, thank you very much for pointing that out, JP. Love
Yeah.
talking to you.
Welcome. Thank you, Shanmugam.
Thank you. Until next time, thank you for watching.
Bye-bye.
Bye.